To welcome everybody here. Um, this is our fourth out of five listening sessions that are sponsored by the Area Agency on Aging. These listening sessions are giving us an opportunity to look at the master plan on aging. And today we're really fortunate to have Dr. Kathleen Sullivan, Vice President Post Acute Care um, from Dignity Health to facilitate today's meeting and to look at the goal 2 called Health Reimagined. And the goal statement, and I don't want to repeat the slideshow, is that we will have access to the care and services we need to optimize our health and quality of life and to continue to live where we choose. And I would like to just note that today's meeting is a Zoom meeting, which will allow everyone to have an opportunity to speak. Please be patient for your turn and courteous to all speakers. We are inviting you to mute yourself while others speak to eliminate background noise and enhance clarity. We are trying to record this session, and if it works out, which it appears to be doing the last several of these forums, we will have the recording available on the Central Coast Commission website. So thanks for participating in today's listening session. As the governor stated when he released this master plan on aging, we can build the age-friendly California every one of us deserves. And we will be doing that locally by working together. So I want to thank Kathleen for leading us in today's discussion. How can we as a community move forward with healthcare, equity, and all the important aspects of access to healthcare? So thank you again, Kathleen, for your time and your expertise and facilitating our meeting. So let me turn it over to you, please.
Thanks, Joyce Ellen, and appreciate, and good afternoon to all these faces I see on our Zoom call. I'd like to thank you too for asking me to be part of these series. Working in healthcare, I work for the 3 hospitals up here in the northern part of Dignity's service area. I'm based at Marion. And as Joyce Ellen mentioned, I have the privilege of working in the non-inpatient side. So I work with a lot of different programs and services that constitute what we call the pre and post care, the stuff that people need while you live and stay independent in the community. So it was fun for me to go back through the master plan. I had been monitoring it, had listened to a lot of the sessions in the early phase of it, but like many healthcare people, was completely subsumed, mired in COVID for close to a year. And fortunately, we're beginning to step on the other side of that, certainly locally, which is wonderful. So in having the chance to look at goal number 2, Health Reimagined, I dug in a little bit, and I'm not sure how the 4 additional of you that have joined us, how familiar you are with the details. So I didn't want to regurgitate the entire document, but talk about a few things that were maybe that were maybe a little more specific to what we might grapple with here. And Joyce Ellen had indicated that her hope was we might have some conversation around, this is great, the 5 major goals within this plan and the 30 some odd major recommendations didn't necessarily come with extensive funding, if any. And perhaps when we think about the recommendations for this particular goal number 2, how we might be able to do that locally. What would we build on? What would we need to replace? What would we need to create that was brand new in order to get traction on some of these recommendations locally. Now, if we are working on goal number 2, Joyce Ellen, I'm assuming that, which is the one that is still left to do?
That's aging and affording aging, goal 5.
Good deal. Okay. So Fernando Torres Gil, typo there, is a guru, as some of you may know, on health policy and aging and public health. And when he looked at goal number 2 and was part of the planning for the master plan, I captured this and I thought it was worth focusing our thinking. When he speaks to aging being a universal process throughout our lifespan, and that health shapes the experience across physical, emotional, social, spiritual, and functional dimensions. Individuals age in the context of their multiple identities, and they're influenced by the communities of belonging. And this last part, the communities of belonging, which is the myriad, but one could be defined as here on the Central Coast, and the challenges and opportunities of our social and political world that make these things possible or not. Within goal number 2, the 6 different strategies that we'll talk about a little bit. The first one bringing the ideas that they brainstormed and gathered under the strategy of bridging healthcare with home. The second one that you'll see, we'll talk about interventions for success under the category healthcare as we age. Then the third one, lifelong healthy aging. The fourth category of interventions, geriatric care expansion, dementia in focus, and then finally the strategies under the category of nursing home innovation. The first strategy is probably the one that I have had the most personal experience with, the most work experience in, and that's the strategies under bridging healthcare with home. The biggest one that got a lot of conversation in the master plan was around how to increase access to long-term services and support. And within that, how to expand community and home-based services, especially around Medi-Cal. Is anyone, any of you on the call familiar with the work that's happening now through CalAIM? Well, CalAIM is essentially, I guess, it's a large project, but it essentially revamps the Medi-Cal program in California, and revamps a significant part of it in a particular way where there should be noting that there should be monies for and services provided through these community benefit organizations, which provide for recipients of Medi-Cal things like offsetting food insecurity, like transportation to the doctor's office, like support with housing or getting into housing, what they call recuperative care, which is not quite hospital, not quite skilled care, not quite home, you're not quite ready yet, and it's called recuperative care, or support with respite care before you get back home. So it's a significant effort that's got derailed as well with COVID, and is back, not on track, but back on the conversation. And it's an interesting thing I would recommend everyone watch. California is particularly noted for its in-home support services program, but as Joyce Ellen, I think, would echo, it is not near what would be needed to support medically fragile older adults trying to stay at home in order to be where healthcare can be acted upon the best, but it's not near enough hours, and the eligibility and the wait lists are extraordinary, and that's for the Medicare patients. And again, Medi-Cal is a big part of that solution as well. The recommendation of building partnerships with stakeholders, care providers, aging and disability networks. There is an example I'll sort of close my piece of the conversation with, of what the folks generating the master plan think is a great example of this bridging healthcare with home, where not the finances of healthcare are augmented, the volume of services that aren't medical in nature that are necessary to remaining at home are augmented, that the support with seniors in particular of navigating these services, getting eligible for services, maintaining eligibility, and support during the entire experience with need are solved. And that's always the challenge. Here within the healthcare delivery system that I work, we have an extraordinary array of services to support seniors in the home environment, including things like transportation, volunteer support, and the traditional services that you expect to receive. Food insecurity being a big one during the window of COVID, and partnering with others in the community to try to solve that. The biggest challenge that we continue to face and solve is how to connect the dots, how to make it simple enough. Once we wrap our arms around a vulnerable senior and pop them into the system, we do a pretty good job about connecting the dots. But the access, getting to that point, getting the right seniors in the right place is difficult. And anyone who's tried to navigate for themselves or for their loved ones, knowing where to go, not just getting information and referral, and then you having to do all the footwork and make all the phone calls, you don't understand the answers that you're providing you, and then they give you 2 more phone calls in order to try to get what you need. I know one of the workshops so far had a lot of conversation around family caregiving, and I'm sorry I wasn't able to get on that one. That is a great personal interest and work effort. We have a program here, for instance, that served over 800 caregiver and care recipient dyads, but it falls into the strategies, the ideas that need to be executed in order to bridge healthcare to home. And maybe pause for a moment. So with what we've talked about on each one, on each of the strategies, any additional thoughts from any of you here on the call that we could capture, ideas, your own experience before we move on to B? Or capture your thoughts, as we walk through it, and at the end, see what might come to mind. Okay. The next strategy in the plan to support goal number 2 was around the ideas on how we could improve healthcare as we age. And I think I've already begun to talk a little bit about those. One major idea was to modernize Medicare counseling services, which right now we have HICAP, which is an incredible service, but it's right? In the Area Agency on Aging oversees the HICAP program, has for some years, and it is probably, Joyce Ellen, wouldn't you agree, probably one of the most constantly accessed word of mouth awareness, but it is still fundamentally an information and referral. And if we had the breadth of people to provide counseling to Medicare recipients about where to go, what next step to take, how to pick this, how to pick that, what am I eligible for, and would have somebody there to make the phone calls for you, that could be huge.
Mm-hmm.
Behavioral health. COVID or no, we have been struggling on the Central Coast across the country, but definitely we've seen our fair share on the Central Coast of trying to build back programs, facilities, beds as need be, outpatient counseling around behavioral health. We used to have a geriatric psychiatric facility in Santa Barbara, but that's been closed for 15 years and nothing has ever opened since then. We see our adolescents who have behavioral health challenges having to go down to Ventura or Los Angeles for any support. And we have very limited short stay psychiatric hold facilities, and our emergency rooms are overwhelmed. And as you can imagine, a busy emergency room is not the place for an older adult who's come in with cognitive challenges. It is a scary, frightening, disabling place when you're dealing with cognitive issues and you need even minor health care. So geriatric emergency rooms, we have one on the Central Coast. French has gotten that designation. I'm not aware of the others reaching that yet, but it's on everyone, including Tenet, as I understand, goals. We're very interested. I am here for the Dignity hospitals in engaging what we may touch on later, but what is referred to as now I'm going to lose it. But basically healthy aging in health systems, and that which is a partnership between the Institute for Healthcare Improvement and the Johnny Hartford Foundation. So I'll speak more to that. The medications. I mean, are we ever going to solve the medication problem? To make more generics affordable? We do a lot. We're forced into a situation where we have to keep creating workaround situations to try to get drugs from sponsors when seniors can't afford them, to have hospitals begin to send 2-week supplies home when a older adult has been in the hospital, because there's no guarantee that that senior is going to be able to get the meds or to get to a place to get the meds. There's just a lot of work, both in cost and design, about how to make sure seniors have the meds they need, and those with disabilities as well, but are focusing on older adults. Is anyone here on the call very familiar with what we call palliative care? And palliative care is fundamentally an approach to care which focuses first and foremost on what do we want? What are our goals of care? What do I want to see happen when this happens to me? What do I want to see happen if I do end up in an emergency room? What if I develop cancer and these two things happen to me? Being clear ahead of time. What if during the window of COVID, I'm 85 years old and I'm active and my cognition is great, but I might not want to be on a ventilator. And it's a very real decision-making point during the window of COVID. And these things about goal setting and being clear at what you want and having your providers know ahead of time before you have an opportunity to deteriorate has taken on new meaning in this last year for those of us working in healthcare. So palliative care is all about helping a nurse, a physician, social workers, chaplains, all wrap themselves around you if you present in the system or in support with your doctor in the community to help you execute advanced directives, to help you just be clear on what and to walk you through what it means to pick this or to pick that. And then enrolled in a palliative care program essentially is for patients who you might not be surprised you had multiple medical problems that that might die within the next year or two, or that pain and symptom management was critical right now, and decision making. And the palliative care staff wrap around, take care of the pain, take care of the other things impacting your quality of life, work with you in the community, and it really can provide tremendous quality of life changes in individuals and families' lives. So we see a lot of requests right now in the healthcare system for palliative care. Our doctors want to call it PAL care because palliative doesn't make sense to people. and they think it's just end of life, and it isn't. It is not hospice. So if next time I get a chance to visit with you, I call it PAL care. You'll know that's what we talked about the prior year. The post I'll call out under healthcare as we age is an important recommendation out of the plan that I lifted for conversation. Again, you've had the opportunity to make your choices, to have someone to be as a sounding board to help you make them. Now let's put it in writing. You might have an advanced healthcare directive, right, but you haven't revisited in the last 15 years, 2 years, whatever it is. And you might have a need to have it posted on your refrigerator in case a paramedic came to the house. You definitely want it front and center if you ever hit any of the community's hospitals. And so that's why they created the post, which is the physician orders for life-sustaining treatment. It is where it's a simple one page. It's where you get to lay out, I want this, and if it looks like this, and I don't want this, and I do want this, and you can get very, very detailed. It is a very helpful document. And in all electronic records, we put it front and center and give you the bright pink copy to take home so that you can put it on the refrigerator. But it was, you know, kind of, in rereading the master plan, it's good to see all of these recommendations put in writing for policymakers to pick up and with advocacy incrementally look to funding. And it's a tool to then educate our own policymakers in our own counties and cities to do things that we can do. But very little of it's rocket science. It's the stuff that we know needs to happen. We've known for a long time, and we've just arrived at a document that shows consensus, I think. So the third strategy area under goal number 2, lifelong healthy aging. Now, if I really understood this one, I would probably but I might lose it. I would push my stand-up desk up because I've been sitting for too long. I would have each one of us stand up and jog a little in place. And then I would go home and walk the dog every single night for the 2 miles. And I might get halfway there. At the very least, I never smoked and never substance abuse. So I'm partway there. But, you know, when do you begin this? So we hear a lot about brain health, which is good. But and we know, of course, about physical activity, nutrition, tobacco, and oral health, and all of that. So all those, this group is saying, okay, yeah, now again, not rocket science, but lay it out, important. But what is, I think, something that has not been given enough shrift and conversation is about the import of isolation and loneliness. We know of it. When we work in the field of aging, or we are aging, or we have friends and family. Isolation and loneliness. Sometimes we, you know, when we have conversations professionally around isolation, being home and independent versus being in a skilled nursing facility. Well, if you're very, very isolated within the home environment and you can't get out, and very few, no family, no friends and around, and very few come in, how is that compared to being in community in the skilled facility? So again, it goes back to personal self-direction, person-centered care. What would I choose? And to have those options. But this last year of COVID put such a exclamation point on the conversation about the importance of addressing social isolation. We had so many people, of course. We have a very large skilled nursing facility, Marion Extended Care, which does a great job. There's all of the Compass facilities that in shared conversations had the same life experience and the goal of helping, where our residents could not see anybody for the longest time, and families could not see their loved ones. Now we got good at phones, we got good at iPads, We partnered with home health agencies to bring iPads out to older spouses in order to connect them with spouses inside. We certainly addressed end-of-life needs by allowing personal visits, et cetera. And all of our community skilled nursing facilities basically practice the same. But it was a long period of time before any touching and hugging could occur. And I'll bring that back up again in a minute. But isolation and loneliness, huge, absolutely huge, as it relates to health. I mentioned before the age, this is my right language, the age-friendly health systems. This initiative is essentially fundamentally working on what they call the 4 M's. So if you ever hear the 4 M's, this is what it means, basically. As I age, I want everybody who touches me in the healthcare environment to know, so how are you going to do that, healthcare providers? I want you to know what matters to me, what medications, I want to know what I take, and I don't want my medications to necessarily interfere with what I want and what matters, and certainly not interfere with my mobility, which is part and parcel to make sure that I can do what matters. So these are all intertwined, and that I want certainly to not have any cognitive challenges, but if I do, that they're identified, we work to prevent it, your partner's with me in this, and that you help me manage it should it be an issue, so that I can continue to do what matters to me and continue to have mobility, and that medications don't mess me up for as long as possible. So it's a pretty simple, but I think pretty elegant model for communication about, as I age and engage with the healthcare system, how we can talk about these. And that means my primary care doctor should be intimately familiar with the 4 M's. If I have to present in the emergency room, I would want them to be familiar with the 4 M's, and I would want people caring for me anywhere in the healthcare system to be familiar with them. And that is a work in process in this country, but more to come on it. Another recommendation under geriatric care expansion is to expand geriatric training, and that's for all levels of clinicians. I think I'd read something like less than 5% of clinicians were actually trained specifically from a geriatric perspective. My PhD, but it's not a medical degree, is in geriatrics and health policy, which is certainly helpful to keep my thinking interested and engaged in this. And we are fortunate enough to have an actual geriatrician running Marion Extended Care. The geriatricians, there aren't that many. And we have been fortunate actually for quite some time that a long-standing physician whose father was a physician here continued the geriatric practice, and now to bring in Dr. Campbell was an incredible find. But we need geriatric nurse practitioners, we need geriatrically trained emergency medical technicians. We need more geriatric trained in the 4 M's, if nothing else, in our primary care practices, et cetera. And then the last one, which was their major recommendation under this strategy, was to diversify clinical and primary teams, aligning with aging demographics. And I think what that mostly gets to is, you know, as I'm aging and presenting and wanting to maintain my health or improve my health, and I want what matters to me in the 4 M's to be incorporated in my care plan, that's going to take more than just your doctor. That's going to take educated mid-levels. It's going to take what we call a new brand of worker called healthcare workers to work with me if I am stuck and I need help with transportation, food, et cetera. I want them to understand what I need as an individual who's aging with healthcare needs. And no recommendation on a master plan for aging would be complete without some recommendations on dementia. Again, nothing that was extraordinary, The biggest one then that I pulled out would be the promoting awareness, more screening, so that it's identified early. We all know that it's not something anyone wants to face, and as individuals, we tend to put it off because once we know, it is a whole different experience. But like anything else, like cancer, early screening, we consider it automatic that every single, every woman should have mammography, should have cervical screening. Every person over 50 should have colonoscopies for colon screening. But we don't do near enough with a public health policy about cognitive screening and brain health and prevention. And then when we do have dementia, that those standards of care are incorporated into Medi-Cal and Medicare as an example, which is within the scope of this document. So what that means, if you read some of more of the material from those working in the field of dementia, fundamentally you could reduce it to that all of these care models that are placed on us as seniors with cognitive issues, they're placed on us. So we need to have better capacity to be able to incorporate person-centered care into these care plans that are going to be placed upon me, that I'm supposed to participate in. They're about me, and that I want more support with transitions, and back to what we were talking about, someone actually helping me doing the coordination and transitions as I navigate the health system. And we'll just talk about the sixth one real quick and then see if there's more questions or ideas we can glean from each other. Nursing home innovation. I'm going to jump down real quick to the fourth bullet. One of the things that I think is most interesting to follow, and that I think we can really do something about in this community, is to take a look again at what they call greenhouses. And these greenhouses were a pilot project in the Midwest some years ago, as I recall, to better conceive what a nursing home could look like. Instead of replacing all of these large facilities that look like, rooms off of a long hallway, a centralized medication room, people going up and down the hallway passing meds, that let's turn these into like houses. So imagine a large living room, a kitchen, and maybe 6 bedrooms off of that area, and a little workstation for a nurse's aide. And a nurse that might go around and see everyone once a day, provide the care that's required, and then go to the next green home and go to the next green home. And if I lived in one of those, I'd have a small room, but it'd be mine. And I would wake up smelling bacon. I'd wake up hearing this clatter and noises of a kitchen, of people who had gathered maybe in the living room and who had turned the TV on to some of the news. And I'd wander out or I'd get support at the right time when I woke up and come on out and get some breakfast, right? That's kind of the flavor of these greenhouses. And if they were funded like a traditional nursing home, that would be huge. It was important to the first bullet, it was important in the creators of the master plan to address COVID. I don't think was part of the original idea by any means when this work began, but it certainly became a big one. At least a third of all of the deaths, as I think we all know, that occurred across the country occurred in the skilled nursing home environment for lots of reasons. And fortunately now that has shifted completely, because that was the first that we succeeded in full course vaccinations. And not all nursing homes are managed the same. And there were undoubtedly throughout the country, nursing homes across the country that weren't didn't plan well, didn't execute their COVID infection control plans effectively, had physical plants that limited any improvement, but nobody had beds to go elsewhere, and that suffered disproportionately. So the authors of this document are calling on a greater reporting and expansion on quality and staffing during COVID, and certainly is still with us today, absolutely. With nursing home innovation, there has always been, at least in the Medi-Cal system, a little bit on what you call value-based payment methodologies, but mostly around value-based payment methodology essentially means that let's put money, let's pay for services that have a quality, lower cost. They're services that meet what they call the triple aim of improving quality, lowering cost, and eliminating disparities. And well, one thing that has been done is to have waivers to allow extra monies in certain counties if a patient would have otherwise, would have otherwise been eligible for skilled nursing, to have them stay in the home with extra support. That's not true in all counties, and waiting list and lack of familiarity, difficulty accessing it if you're the one putting it together for new residents, for people trying to stay in their homes. But that should be expanded. So we could do a lot more. You know, you'd have to have more of a value-based payment. So to build these greenhouses, that if you had a lower cost of care and you had much better patient experience, you had longer periods of engagement and quality of life metrics, depression metrics, that these greenhouses should get paid more money. And so it would encourage the development of them. And that's what you call value-based payment methodology changes. Veterans homes, still a huge topic. They recognized it and incorporated that into the document. And I threw back in not just the reporting on the COVID and the transparency, but actual innovation for ongoing readiness. The picture that you see in the bottom right is a device that was put into place in my immediate backyard at Marion Extended Care so that we could try to get to some sort of visitation as soon as the county put it out there for possibilities. And it was built by one of the maintenance guys who has a labor of love, you know, put it together and polished it, and it's plexiglass. And you see there that there are shoulder length gloves that go through these holes so that you could actually touch your loved one, even if you couldn't get past the glass. And that was such a huge hit. We still use it, but we've progressed now that if family members come in with their vaccination card and our residents have been vaccinated, they get to hug. But it was an example of innovation, and that made a big difference. So that's the 6 categories of recommendations. And this was the organization that I mentioned to you that was highlighted under goal number 2 on health as a best practice, as an example of this coming together. And Partners in Care has been around for a long time. It's an offshoot of a foundation put together over 20 years ago, and then additional grants, such as from Hartford, who've made a lot of their big projects successful. But you can see when you link to the webpage, this is just a snapshot of it, you can see the kinds of things that represent this comprehensive, addressing social determinants, improving mental health, and supporting dementia, supporting home-based care in lieu of facility care, chronic disease. And you can see that peppered. So care transitions, partners at home, home meds, RX, health homes program, community-based adult services, the MSSP program, assisted living waivers, all the things we've been talking about, the fall prevention, physical activities, telehealth. So I could see what the creators of the master plan meant by calling this out as a potential best practice to look to. So I just wanted to share that with you as an example of this coming together. And that's pretty much as far as formal conversation that I had, just to stimulate any additional ideas that anybody might have that we could capture locally, or any thoughts that you've had about the plan yourself.
Well, thank you, Kathy, for getting us started. So let's open it up the lines, as they say. Who'd like to share some thoughts and comments, please?
I will.
Great.
Hi. Tari Linala, San Luis Obispo. Thank you, Kathleen. That was very helpful. I'm thinking about how the dementia community, like Alzheimer's Association, is doing a good job of reaching out to people and educating families about dementia and how to receive the best level of care. And I'm thinking about hospitals, of how you guys are doing a great job of giving a continuum of care to people that come in the hospital. I'm really happy to know about the geriatric focus. So I look at things towards the front end of the problem. People don't plan for aging as much as they should. So, you know, you all realize that we need to get the durable powers of attorney for healthcare documents out at the age of 18. And then people update them as they live and their life changes. So how about the hospitals? When there's contact with a patient at a hospital and they're 18, you go ahead and give them a flyer on all this, as well as the care for that you're going to give great quality care to a senior when they're getting out. You're going to follow up. Well, let's start that front end process and give everybody some of this information in a culturally competent way that they could start planning at a younger age, at any age, to support their parents and themselves as they age.
Thank you for that.
I'd like to hear from anybody else, but I work with a group called Slow Village, which is part of the Village movement.
Mm-hmm.
And we try to keep older people engaged and offer some services to age in place through volunteer efforts. And we enjoy working with the hospitals and with the Area Agency on Aging and all of the rest of the continuum of care very much. Those greenhouses were a great idea. We did a small group work here in San Luis to say, how could we live well in our older years? And we looked at the infrastructure of that group living as being not affordable to the people that were involved in that focus group. So what we did was we focused on going out as volunteers and the village movement. And we think that is a wave of the future and something that is sustainable and can receive funding along with some of the other programs. So thank you very much. Really appreciate the chance to weigh in again.
No, I appreciate the input. The Slow Village, yeah, I love the village idea and have followed that since the, what is it? Was it Alta Bates or up in the Bay Area, which was the first one?
Yeah, Boston, Massachusetts may be the first one, but Ashby and Berkeley and San Francisco has a great village, and there is a statewide village consortium called Village Movement California.
It's one of the possible solutions.
So anybody want to share some other thoughts, additional thoughts, Taria? You know, we're writing down everything, of course, to, you know, to look, see how we can move forward with all these ideas, but let's try and hear from everybody. When you heard those, that information about all these possibilities presented in the plan, what do you think we need here, and how would you possibly suggest we go about it? Like, who doesn't like the idea of a greenhouse movement here in our community? How might it happen? What if you always thought would be an ideal thing to help you age successfully?
I have a thought. I'm Meredith Bates and I live in Morro Bay, and I'm also a part of the Slow Village like Taria, and I fully support that whole concept as far as aging as part of the continuum of care, as a way for people to stay living in their own home, which I think many people want to do that. I was really interested in what you were talking about, Kathleen, and thank you so much for the presentation, and Joyce Ellen for having these listening sessions. What a great way to get input from our communities about aging and what it means and how we can give you some ideas about what our community thinks. But I was really interested in the palliative care discussion, and that you're kind of changing its name, which I like. I think for me, one of the, and I think you already know this, but most of the agencies that provide palliative care here, it's their name has the word hospice in it. And people just have this, you know, many people don't understand hospice and it freaks them out, and they think, oh my God, that means I'm dying. And palliative care, especially the way you explained it so well, it does, you don't have to be dying. It's not that related to hospice. So I don't really have any suggestions unless we ask these agencies to change their names. But it would be good to just get more education, I think, about palliative care out into the community. I was recommending it to a 90-year-old friend's daughter recently, and she had never heard of it. I mean, that doesn't mean people haven't heard of it, but I was trying to explain it in a good way, but also say, well, it's going to be called hospice. The agency has that in its name, but don't think that means she has to be dying. So I would just like to see more education about palliative care.
One of the terms that you find used, I haven't seen it here, is advanced illness management. So it's a program that supports you with advanced illness. And that's not as scary as what is palliative. Palliative means, you know, it means different things to people. And you're right, it tends to be linked with hospice and palliative care, and it's not. So, but advanced illness management is another possibility.
That's a good idea.
I think, you know, and in revisiting this, it's, you know, fun kind of doing this. Advancing the 4Ms, I think, in many venues, using that as a framework so that we're all speaking about, you know, we talk about person-centered care, then we talk about the 4Ms and what matters. Generally, person-centered does matter, but I love the idea of the 4Ms and the possibility of incorporating that into multiple places within the healthcare continuum for that older adult's touch. And that seems easy enough.
Well, certainly the healthcare system has the whole aging movement, the whole aging of this country sort of thrust upon them. And geriatrics is still not a very popular portion of healthcare. I mean, or where people are, you know, I don't know if you look at when nurses come out and, they all want to go into some other field, how many really want to go into geriatrics? Because in a sense, most of us are limited when we think about aging, about skilled nursing facilities. So maybe the first thing we need to do, or one of many things we need to do, is look at how are we going to change nursing homes. I mean, I think that and developing long-term care in the community, not just in facilities, has been a goal for decades, but there's been rarely enough money behind it. But it is good to see Medi-Cal and Medicare looking by having these innovative ideas and models being developed. I mean, without the funding from Medicare and Medi-Cal, there isn't money to make these cultural shifts in our thinking, let alone the implementation. So how do we, as a community, how do we get that started? Is it, how can we bring together, the healthcare system or the systems that exist in our community, the nursing homes that exist in our communities, and work towards perhaps, not necessarily taking money out of their programs, but adding to our communities funding to, create these new partnerships. I mean, and yet when planning started on the master plan on aging, they made it clear there would be no funding increases. And the funding increases we see now through the COVID are really what's moving some of these ideas forward, whether it's, I always forget the title, but the seriously addressing the homeless situation. I mean, yes, we need that desperately. And perhaps out of that, the community mental health system will be revitalized. I mean, there's just so much potential in these trillions of dollars engaging in, the COVID from both the federal and of course the state level. I mean, when I came out of college, I thought, oh, I want to be a geriatric social worker. I didn't know the term at the time, but I thought, oh, I always tell this to people. My story is, I thought I'd, go talk to a couple of doctors' offices and ask for, just ask for a desk in an office and be their social worker. So people on their way out would be referred to me, and we talk about, okay, so you need transportation and you need some home care, and have you ever thought of adult daycare? Well, I mean, to me, that would be the way to hit the healthcare system. But doctors are just, it's not an interest. And even when Medi-Cal, I can't remember the name of the program, offered some funds for that, it was so, or was it Medicare? It was so complicated. I don't know that any doctors even signed up for it. So what can we do here, even if we just start with the skilled nursing facilities? What would each one of us, if we could make one change in the skilled nursing facility to be more patient-oriented and safer and healthier, what would that be?
I would raise the wages of the workers. I think they're underpaid and overworked. They have too many patients to look after, and their work is vital, and they're undervalued and underpaid. And I think that would help in many ways because their patient load could be reduced. They wouldn't have to work 4 different jobs just to pay their bills at home. And I mean, that's maybe a minor thing, but I think that could go a long way.
Maintaining a strong ombudsman presence and program in skilled nursing would be really important to, as resident advocates.
Other thoughts? These are great ideas. I mean, I don't know what, we have to look at what can we do locally? What would make a difference? Especially since more skilled facilities have become for-profit operations.
Well, like the hospitals are charged with not having people come back to the hospital. And I think they're doing a great job of addressing that. So if skilled nursing facilities could be, have a goal of sending some people home that couldn't handle that and providing the proper level of care in the home, that might reduce their costs and allow them to provide more services for the people that are there, such as, therapy.
I'll just, Tori, I'll just add to that. There are two programmatic and payment models that allow that. When we had COVID, every barrier was removed, and a hospital could provide hospital level care at home because beds were at such a premium throughout the country. That wasn't as much the issue locally of beds as it was staff, so we never did that. But there is still an opportunity to enroll and to provide the hospital at home model, or the skilled, I forget what they call them two different things. But basically it's payment for a level of care in the home in lieu of hospital days, and it's payment for a level of care in home in lieu of skilled nursing care days. So you build the equivalent of resources and move to the home to provide it instead. So you don't have the administrative bricks and mortar cost of care. Now, that hasn't been done much in our area because it's different. It's a staffing difference. It's hard to do. It's hard to say we could do that on the Central Coast, but it is certainly an idea because part of that's already built.
Well, it sounds like that could also build a funding foundation for enhanced services in the home. And we do have some of the basic services that potential patients, for this type of a model would need. But again, they probably are less expensive. The IHSS rate in San Luis Obispo is over $15 an hour to the worker. Now, that didn't just happen. That happened in the desperate need for workers. So, again, the costs within healthcare are certainly higher, but perhaps it could be part of a new partnership type of arrangement when different services are going to be part of a funding scheme to make sure that nursing home care can be provided in someone's home.
A lot of our systems, as you're pointing out, Joyce Ellen, are segmented. So if residential care facilities are more in touch with nursing facilities, and hospitals are more in touch with both of those guys, and we're aiming at the families to be as educated as possible, and also promoting competency on geriatric issues among medical professionals, doctors and staff. We go to the community college and say, let's start in the front end with nursing. So another thing that I'm thinking of is some type of oversight besides licensing, where it's oversight that provides the best practices up front, rather than as a penalty after you commit a violation, but work together more, and perhaps people from HICAP, let's just say, could go out and see residential care, and they would learn that much more about how the system works for older people. We do this on as many levels as we can reach, so that we have the right minds giving advice or think tank experience to the professionals that are doing the work.
Now, Joyce Ellen, I didn't read about this in the master plan review, but you know, like the age-friendly health systems, there were huge age-friendly community initiative that's at least 10 years ago. Or what, is that still active? Is there any?
Yes. Age friendly is through AARP. There's also dementia friendly communities. There's a couple of variances, varieties. It could be something that we could look towards applying for the designation, and hopefully then some funding that would come along with that. It's a very real possibility. Ventura County has developed a dementia friendly community. The county invested a lot of staff and funding to make that happen, and I haven't seen the numbers recently, but it looks like it's a pretty successful program. You know, I think that could be a possibility if the state, for example, would allow some what's the word I want, pilot money, you know, initiative funding to get every community in the state looking at that as what it would take to make their community unique and age friendly. I think it's a possibility.
It was just seeming like if it was, and I appreciate hearing about Ventura's success with dementia friendly, it provides a framework, right, to put all these ideas under. It provides some funding, and it provides recognition, I guess, by other funders like Hartford or others interested in investing in continued innovation. And if we had a age-friendly community designation that had particular pockets of successes about what we're talking about today, then that sort of gets teed up, right, and recognized and refunded, and this innovation is picked up and finally gets paid for under traditional policy. That could be interesting.
I agree. It's fine. I agree. I think, but someone has to take the ball, and someone has to ensure others that it's not a takeover plan. It's a coordination plan. And I think that's the key. Some neutral entity who is acceptable to everybody in moving forward. Some planning. I mean, and that's a tough assignment. I think it's a tough assignment, but I think it's doable. Doesn't mean we shouldn't be working on it.
Put it on the list.
There's some truth to that list at this point, you know. But, you know, sometimes I think in these types of meetings, we need to think beyond the realities, you know, what it would take. put some exciting ideas on the table and then, see what might come of them. I know that, part of the AAA goal is to share the inputs from these listening sessions, not just to the state of California to whom we have to report these things, but to the community, to figure out how to do that and see if we can't move forward with new partnerships or whatever it might take. I mean, one of the things that seems so clear is, what are 3 things we could do to improve nursing home care without spending more money? I'm sure there are 3 things we could do. The first one comes to trying to build a volunteer corps in every facility. Helping to expand the existing friendly visiting programs and telephone reassurance programs that we have in the community. I mean, certainly COVID has taught us that we need to look at the isolation and the resulting mental health issues with that. And how can we help our programs expand those? I mean, they exist, but they're all hampered by lack of volunteers and some of the specifics. I mean, that may be too grunt level, but when I look at, there was a report maybe 12 years ago, 15 years ago, that looked at volunteerism in this country by, maybe it was MetLife or some entity like that. And they asked people why they didn't volunteer. And 40% of the respondents said, nobody ever asked me. And it seems to me we need to start making the big ask, because we have a very diverse and fairly well-educated community that could, with good training, be fabulous volunteers in all of these activities. The Village is a great example of the significant use of volunteers to meet needs that seniors present. And we have other programs they need great expansion.
Thanks for that. So the motivation of why somebody becomes a social worker or a nurse, it's not the money, right? So it's something to do with wanting to give back and help people, maybe help older people. So if we can find out and focus on their motivations, I'm sure they'll be continually improving rather than burning out. So there's some things that our personnel and our training can help with.
Good idea.
If it's not fun, we're not going to do it. Well, maybe don't go that far, but work with the motivations and the reward.
Yeah, that's a good point, Taria. It's like, why do people volunteer? And they want to help others and have a purpose. I think, Joyce Ellen, you were starting, or maybe it was Taria, talking about partnerships with other organizations that already have volunteers and trying to, create motivations for another organization's volunteer in a related field, like the Alzheimer's Association or a program that deals with, I'm thinking of the Cayuga Senior Center and how when they had outdoor events, when they had the lunches, once a month, Bayside would cater the lunch and Bayside would bring some of their residents to the luncheon. And I don't know if that attracted volunteers or not, but that would be an opportunity for these two groups to get together and have some kind of mutually beneficial engagement. So I think if there were ways to coordinate activities with some other nonprofits, that might help people see the need. Are you talking about people aren't asked, but maybe if they were aware of the need for volunteers in nursing homes, they might be more likely to step up.
Thank you for sharing.
That's, you've given me food for thought just within our own skilled nursing facility about what we might be missing with an opportunity for volunteers. We have a volunteer pool, but not one dedicated for the skilled facility, or recruited for, or asked for, using language that builds on the incentives of someone who might want to give back in that environment. Anyway, thank you.
Yeah, just for an idea, sometimes staff is motivated when they have volunteers come in, and the staff gets to interact with them and share, this is what we do, and they learn from each other. I keep looking at Sharon here, hoping Sharon will unmute and tell us what some of your needs are.
Well, I was thinking about the palliative care thing. My husband passed away about 5 years ago from gastric cancer, and they were just starting up a palliative care program at the Cancer Mission Hope in the Cancer Center. And it's really funny. I don't think it ever really got off the ground, and it was never explained properly, although I knew it wasn't the same as hospice. And that it was not hospice. I knew that much because I researched it. And I don't see much going on in the palliative care area. Kathleen, can you shed a light on that?
Yeah, I can try. From my lens, so it's interesting, hearing yours, but it's 5 years later. I have a husband who's walking a path with gastric cancer at Mission Hope right now. So there's an interesting parallel, just personally.
Yeah.
There have from a cancer center perspective, there have been several efforts to have palliative care physician and palliative care nurses there at Mission Hope in a clinic. What we learned was two things mostly. One, that medical oncologists, particularly the ones there, the ones I know the best and up north at Sloan Oncology, are so comfortable typically with engaging with those conversations with their patients, and they don't want to give it up. And that was okay, that's good, but it maybe doesn't give that patient the dedicated amount of time that would be beneficial on top of their interaction with their medical oncologist. So it's worked so currently pretty well to have a community-based palliative care program. So we have a nurse practitioner and nurses and social workers who go to the patient's homes, and allows a longer one-on-one response to the need for a palliative care consult for pain and symptom management and decisions, etc. So that's been effective. On the hospital side, on an inpatient, it's been a hue and cry for it. But what I hear is doctors asking for it, nurses on the floors asking for it, and that's progress. That wasn't always true.
Yeah.
Now, are the individual patients asking for it? No. But the providers working with them are bringing in their colleagues in palliative care as quick as they can these days, which I think is tremendous. That's just a few thoughts on it.
Seems to have changed somewhat in the last 5 years, and which is good to hear.
I think 5 years has been substantial, yes. Not
Yeah.
much before that. It's really been the last 3 to 5 years.
They were just starting it when my husband was still alive. Yeah, in the end, I mean, he passed away anyway, but it would have helped for a while.
That sounds about the right timing. Yeah. No, I appreciate your input.
Fortunately, I'm not in the need of palliative care.
No, and that's good, but you, even after our conversation today, have a little bit more to carry back to a friend who might
Right,
be.
exactly. Yeah.
Thank you both for sharing and sharing.
Yeah. Well, you know, there's another thing you were talking about. I have a bad back. It's been coming on me for a while. And so I'm going to have a pain management procedure this week. It's kind of like an epidural, but not quite the same thing. Anyway, I'm trying to avoid back surgery. I mean, you know, it just, who wants to do this? And a couple years ago, I had a rotator cuff surgery and I had to get home help that I paid for out of pocket because I couldn't, it was my right arm and I'm right-handed and I couldn't use my right arm because I was in a sling. But you know, there's not a provision for that kind of assistance at all out there now. I mean, I remember I had 2 knee replacements many years ago. And like my husband was still alive then, so I was fine, you know. But what are people doing these days when they're faced with that kind of thing? It's really terrible.
Yeah, I mean, it's huge.
Yeah.
And you know, as my mother says, you forgot to have children. Well, I didn't have children, so I don't have that additional layer, even if they, you know, you might not
Yeah.
live near you. Anyway.
Well, I don't have kids either, so there you are. Who's going to?
Yeah, exactly. So I know, for instance, in Joyce Ellen, you're probably much more up on this than I am, but now, for the last couple of years, most of the Medicare managed care plans that you might participate in or choose to participate in offer this extra benefit of, forget what it's called, and they're not doing a good job yet at educating those who have the insurance and actually knowing what it is they're going to pay for, whether they're going to pay for exactly that, an aide to come to the house to help you get settled or to do some food preparation, things that are going to get you through
Yeah.
get your pants on or, you know, a shirt on. And I forget what that's called, but that's a big step in a Medicare beneficiary being able to have some funding in a plan if we can figure out how to ask for it and pay for it. But it's
You're talking about Medicare Advantage, right?
Yeah, exactly.
Yeah.
And it's a great sales point for the Medicare Advantage plans, which our TVs are filled with. It doesn't really turn out to be exactly as it's presented, and that won't surprise anybody here. But one of the things, there are some bills because Medicare has allowed this with Medicare Advantage plans, but not with regular Medicare. And that seems to be quite discriminatory when you think, people who have purchased Medicare and have a supplement insurance, why wouldn't Medicare pay some portion of such home care, meals, transportation, all those things they advertise.
Right.
It allows Medicare Advantage to offer them. And the few experiences we've had, so I don't want to make this a general statement, with people who have bought those plans with that expectation have not been positive. So,
Yeah, I knew that. Yeah.
so, again, why do we offer something to a particular commercial product that we don't offer to, or what's known as original Medicare? I think
The
it's
original
a great,
Medicare, right. I have original Medicare through my former employer. It's a
right.
benefit.
So, we certainly support those programs. I mean, that's what we hopefully have built the foundation for somewhat in our communities. But again, why is Medicare discriminated against? Probably about 60% of their beneficiaries. It's a pretty, we think, discriminatory practice.
I think it is. And I really think if Medicare could change their tune, it might enable more people to stay in their homes. And,
Exactly.
I mean, unfortunately, I have the resources to be able to pay out of pocket. That's, but a lot of people don't have that. And it's pretty bad. Anyway, that's what I have to offer.
Absolutely right, too.
Yes, I would look forward to some studies that look at original Medicare and Medicare Advantage in terms of home care issues. Something has got to move this forward because this is definitely a concern among many people who are Medicare advocates. And I actually think Ron Wyden from the U.S. Senator from Washington has or will propose a bill about that. I read that somewhere.
Oh, really? He is? I didn't know that.
As soon as I find it, we'll put it on the agenda for our advisory council.
Yeah, well, we know what really bothers me about Medicare. It's billed out there and advertised as a commercial product. And you're going, wait a minute. You know what I mean?
Mhm. So I'm going to ask this as a question. When you're facing a procedure like that to avoid surgery, and maybe you have to go to a doctor's office or maybe even a hospital to receive that,
Right.
well, maybe that agency can help. I mean, if it is at a hospital,
Oh, this procedure doesn't require any home care.
it doesn't require any home care.
No.
Okay.
I just need a ride to get there. That's all.
Okay. Yeah. Ride On offers low cost rides.
Right. Exactly.
Any of these folks can refer you to some help for that, I think.
Thank you.
By Meredith. Well, it's be good to hear from Diana. Diana, you're doing the listening session. We'd like to hear from you. Thanks, Sharon. That was really helpful.
Well, I hope so.
Is our host talking, but she's muted? There we go.
Thank you very much for the continued help, how to use this technology. Maybe it's a good time to ask if there are any other comments that any of you would like to share. I know we only have a few of you left, and I hope everyone who wanted to say something has said something. Any more comments to share? Well, let me just then bring this to a close. And I really want to thank everyone, but I want to make a special thanks to Kathleen Sullivan. I mean, your expertise and knowledge really, I'm sure, stoked a lot of ideas, and that's really what we want. We are very interested in creating an age-friendly community, and I just want to repeat the framework that was provided when they first started work on the master plan on aging, because I really think it's germane to everything that we do. I want to choose where I live and have the help I need to do so. I want to live in an age-friendly community. I want to have good health as I age. I want to be financially secure and safe as long as I live. So I think we hit the target on several of these areas today. And I just want to remind you, we have one more session left in our listening session series on the Master Plan on Aging. The next one, or the last one, is Wednesday, May 12th at 10 o'clock. It's regarding Goal 5, which again could be very interesting. Like today, affording aging is the topic. It'll be led by Esmeralda Garcia. Esmeralda is a social worker supervisor over at the County Department of Social Services and is a very passionate advocate about adequate financial resources to maintain safety and security for older and disabled persons. So I hope you'll plan on attending. Special thanks to Kathleen and everyone. We were a small group today, but I think we came up with some meaningful ideas for our local community. And that's really what we're all about, trying to move forward, as no matter how slowly or incrementally it takes, we are going to get there. And the best way is together. So